Ну, еще до начала. So, dear friends, good morning. Let's start our meeting, the conference, the section, the young investigators contest. And so we have 4 jury members, Professor Джиоева, Загидуллин, Аргунова, the PhD Namitokov, and Sokolskaya. So we'll drive through the whole section. So, and we're happy to invite Berdasheva Victoria Alexandrovna from St. Petersburg for the report, atrial fibrillation and obstructive sleep apnea syndrome results of a retrospective study. Please, 6 minutes. You come here.
Good morning, dear members of the jury, dear colleagues. Let me present to your attention the results of our study. Atrial fibrillation is one of the most common arrhythmias in the world. Over the last 20 years, the incidence of newly diagnosed atrial fibrillation and the prevalence of this arrhythmia have increased. Among potentially modifiable risk factors, such as hypertension, obesity, the influence of obstructive sleep apnea syndrome on the development of atrial fibrillation have recently been discussed. The pathogenetic mechanisms of atrial fibrillation development in patients with obstructive sleep apnea are characterized by hypoxia and hypocapnia, leading to chronic inflammation, fibrosis, and negative intrathoracic pressure also promotes atrial dilatation. The purpose of our study was to examine the incidence of atrial fibrillation and atrial remodeling in patients with sleep apnea identified during screening respiratory monitoring. A retrospective analysis of 291 medical records was performed on patients who underwent screening respiratory monitoring based on clinical suspicion of sleep apnea. According to our study, the incidence of atrial fibrillation in patients with sleep apnea was almost 29%. Breathing disorders of varying severity occurred with the same frequency. And atrial fibrillation was more often detected in patients with severe apnea compared to patients with mild apnea. What was the difference between patients with sleep apnea in combination with atrial fibrillation and without with rhythm disorder? Of course, patients with atrial fibrillation were older and more often had chronic heart failure and thyrotoxicosis. There were no difference in other comorbid pathologies. In mild apnea, the paroxysmal form predominated, but in severe cases of apnea, the permanent form was observed significantly much more often. And we divided patients with and without arrhythmia into 3 apnea severity levels and analyzed echocardiographic parameters. And it has been shown that remodeling of both atria were higher in patients with severe apnea compared to patients with mild and moderate apnea. And then we divided patients according to the forms of atrial fibrillation. And it was shown that in patients with a paroxysmal atrial fibrillation and severe apnea, the sizes of both atria were greater than in patients with the moderate and mild apnea. And among patients with the so-called stable form of arrhythmia, persistent, long-term persistent, and permanent, they almost all had severe apnea. And what was interesting, in patients with stable form of arrhythmia and severe apnea, the volume of right atria were significantly greater than in patients with a paroxysmal form and severe apnea. perhaps this is the one of the reasons contributing to the persistence of atrial fibrillation and worsen the results of cardioversion in these cases. So atrial fibrillation and permanent form of atrial fibrillation are more common in patients with severe sleep apnea. Dilatation of the left and right atria is more pronounced in paroxysmal atrial fibrillation and severe obstructive sleep apnea than in mild and moderate. And dilatation of the right atrium is significantly higher in stable forms of atrial fibrillation in combination with severe apnea than in paroxysmal form and severe apnea. Dear colleagues, thank you for your attention.
Colleagues, do you have some questions?
Thank you so much. Thank you so much for very interesting presentation. One question. Is it possible that two groups and they have the significant difference for the age?
In our case, yes.
Yes.
Yeah, thank you for the question. Of course, patients with atrial fibrillation were older because it was cohort of hospitalized patients. And of course, we have some limitations because these patients were older. And of course, we compared them because we don't have another group. And of course, maybe the sizes of atria and the volume of atria were bigger in patients older, but the difference between age were not so big. And yes, and of course they had heart failure, so, but it was a retrospective study, so we just analyzed what we see, and we will continue our study in prospective, and maybe we will see.
You need to do the propensity score matching to balance the group. This is the answer.
Yes, we will do it. Thank you for your comment.
Who is the most well-known literature hero with sleep apnea?
Literature here? No, a doctor, no medical.
Well, it's a hero. He's not the main hero of this Roman, but he's very well known. The same.
You should say century and the country.
Country, okay. It was this.
Yes.
Okay, the same question to all our guests. What was his name? Not author, but the hero's name. Okay, the hero's name is Joy, and he was not main, but one of the heroes of Charles Dickens' Pickwick Club. Yes.
Okay, Ali Muradovich, your
It's interesting.
intellect is very high, so we do understand it. Okay,
Thank
you
you
very
so
much.
much.
So you may sit.
Dear colleagues, and the next speaker is Blinova Anna from Kemerovo, and we are very glad to see you here.
Good morning, dear colleagues. The report was prepared under the guidance of academician Leonid Barbarash. Acquired mitral valve diseases are the most common valvular heart diseases. Mitral valve repair is the gold standard for mitral regurgitation in young patients because of better flow dynamic and no need for anticoagulants. Choosing treatment modality for older patients is very controversial. For mitral annuloplasty, scientists at the Research Institute for Complex Issue for Cardiovascular Diseases with the specialist NeoCore have developed the NeoRing biological annular rings, which ensures the preservation of the shape and biomechanics of the native mitral annulus. According to the recommendation, it is better to use biological heart valves in elderly patients with acquired heart diseases. But why specialists at our clinics have been using a domestically proceed third generation and epoxy treatment biological prosthesis Uniline during 15 years. The aim of the study to conduct a comparative analysis of mitral valve replacement and repair in the treatment of mitral regurgitation in older patients. The study includes 19 elderly patients with primary resulted mitral valve regurgitation who underwent mitral valve repair with annuloplasty using the neo-ring annular rings of mid-inch rigid ring at our institute. The specified parameters were gender and age. Also, we select 19 patients who received the Uniline biological prosthesis. Men privilege in both groups, the median age was 16.8 years. The predominant etiology of mitral regurgitation in the mitral valve repair groups was connective tissue dysplasia. The etiology of disease in biological heart valves recipients varied. The groups didn't have statistically significant differences in the frequency of concomitant diseases. Patients undergoing mitral valve replacement were treated using only size 50 of biomechanics or biological heart valves. Annuloplasty was conduct using the rings of different size. The groups didn't differ in the times of aortic cross clamping and duration of cardiopulmonary bypass. Cardiography showed what the recipients of the Uniline by prosthesis had a lower left ventricular ejection fraction, higher pulmonary artery pressure, and larger left end ring atria. Following mitral valve repair, patients showed positive changes in the parameters of the left ventricular and regression of pulmonary hypertension. At the sometimes Uniline recipients showed insignificant changes in the comparable parameters. There was one case on July diagnosed atrial fibrillation and 2 hospital deaths in the mitral valve repair group. One fatal outcome occurred in the groups of Uniline recipients within the year. The research results show that the outcomes of mitral recipients using biological heart valves in older patients incomparable with mitral valve repair outcomes were gold standard for treatment of mitral regurgitation. Thank you for your attention.
Thank you so much. Excellent presentation. What is the design of your study? Retrospective or prospective?
Understand?
Ретроспективно или проспективно?
Retrospective.
If you have the retrospective design of study, you cannot, how to say, to explain outcomes, because retrospective study can study only associations, but not outcomes. So if you have prospective study in 2 cohorts, you can study the outcomes. Retrospective study only association.
Anna, thank you very much for your report. Could you tell us, please, what is the future of this study? You show us the retrospective data, but will you include another patients in prospective?
Understand.
У вас сейчас была показана ретроспективная часть исследования, всего 19 пациентов в каждой группе. Будущее этого исследования есть ли? Планируется ли перспективный набор?
Yes, of
То есть
course.
вы проводите анализ сейчас в рамках...
У нас проводится, то есть, огромное исследование по юнилайнам, именно и по биопротезам, и по...
Okay, they
опорным
plan.
курсам.
Я позволю себе комментарий на русском языке. Замечательное исследование. Вы исследуете 2 когорты, но только дизайн, он может иметь характер ретро-проспективного. Сейчас вы изучили ретроспективную часть, а в последующем, если вы сделаете проспективное наблюдение за этими пациентами 6 месяцев, год, то тогда можно уже говорить о каких-то исходах. Ретроспектив позволяет только ассоциация.
Okay, thank you very much. You may sit. The next is Simjit Khunhinova from Tomsk, the 5-year study of renal denervation patients with resistant arterial hypertension. Please, come on.
Good morning. Treatment of hypertension is one of the most effective mechanisms for reducing cardiovascular risk. Hypertension control remains quite low, and radiofrequency renal denervation is a method that destroys sympathetic nerve ganglia in the renal arteries, showing effective in treating hypertension. Leading European expert recommended this product for hypertension treatment in 2020. 3 years. There is not enough long-term data beyond 3 years. Several questions remain open, and the hypothesis our studies that renal denervation possesses pronounced and long-term antihypertensive and organoprotective effects. The aim of the study was to evaluate the long-term antihypertensive and organoprotective efficacy of renal denervation in patients with resistant hypertension based on 5-year follow-up. Our study is prospective observation of 43 patients, patient age 40 to 80 years with resistant hypertension, characterized by uncontrolled blood pressure, despite the use of 3 antihypertensive drug, one which of or more, one which is diuretic. Renal denervation was performed of them. All patients initially and after 5 years of follow-up was measurement of office blood pressure and 24 hours ambulatory blood pressure monitoring, echocardiography, measurement estimate glomerular filtration rate, and 40 our urine volume, urine protein, albumin excretion, calories, and natriuresis. Inclusion and exclusion criteria were standard for study of renal denervation. Primary efficacy endpoint of renal denervation was a reduction in 24 hours systolic blood pressure. Secondary endpoints included achievement of target blood pressure level, and responders were defined and individuals with a reduction in 24 hours systolic blood pressure and 5 mmHg or more. On the left, in a decrease in office and ambulatory blood pressure after 5 years. In the main group, an average decrease in daytime systolic blood pressure of 80 mmHg was achieved without noticeable change in the use of antihypertensive drugs. Target level of clinical systolic blood pressure was achieved in 15 patients, and echocardiography revealed a significant decrease in intraventricular septum. Annual decline estimate glomerular filtration rate approaches the physiological norm, and however, However, in increase and daily natriuresis and diuresis was noted. In addition, correlation analysis revealed a direct relationship between the magnitude of reduction in daily systolic blood pressure and the increase in daily sodium excretion. The response rate after 5 years was 22%, and they differed from the non-response group. The baseline higher values, 24-hour systolic blood pressure, pulse pressure, blood pressure variability, and the prognostic value of the initial 24 hours systolic blood pressure, its variability and kaliuresis, and confirmed by the result of ROC analysis. In conclusion, renal denervation in patients with resistant hypertension is accompanied by a stable antihypertensive effect during a 5-year follow-up, which is associated with increased natriuresis and the absence of significant progression of renal dysfunction. And the predictor of a significant decrease in blood pressure after 5 years is the baseline high daily systolic blood pressure, its variability, and high kaliuresis. The after personal contribution and acknowledgement and limited our study presented on slide. Thank you for your attention.
Thank you very much. I have one question. Could you tell me, please? You showed us the 5-year results. It's very long period of observation, but I want to know the main novelty, the new findings of your study.
Okay. Sorry.
And your role in this study, what did you do?
Okay.
Your function.
My contribution in observing a patient on 5-year follow-up, and I analysis and statistic processing and write, and we continue study, and this topic is my planned dissertation. It's a start of my work.
The principal new findings of this study, which comparable or not comparable with the studies from international publications. Принципиальная новизна, какая исследование по сравнению с данными международными и так далее?
Thank you so much. I'm sorry, my English not well. Because 5-year results is very after 3 years results is huge, but results after 5 years мало. Более, да. Thank you so much.
And did you look for the endpoints? Some MACEs, stroke, myocardial infarction, death?
In study of renal denervation, endpoints, main endpoints is reduction to daily systolic blood pressure, and it's a standard endpoint in study of renal denervation.
This is secondary endpoint actually. So the primary point usually it's the MACEs, development of MACEs.
We plan to working, and it's the future in data future.
One question. Thank you so much. And now in guidelines 2023, we had renal denervation, also like an additional method of correction of hypertension. And what about our patients after denervation? Should we consider an additional nephroprotection?
Nephroprotection is a topic of our study, and we работать над этим.
Вопрос в следующем. Вот метод ренальной денервации, он вошел как дополнительный метод коррекции резистентной артериальной гипертензии. Но в настоящий момент есть некоторые антигипертензивные препараты, которые оказывают в том числе и нефропротективный эффект. Как мы видим, метод ренальной денервации, он, во-первых, имеет ограничения, его можно проводить только пациентам с расчетной скоростью клубочковой фильтрации выше 40. И если они теряют на 12%, это немало. Должны ли мы рассматривать после ренальной денервации всем нефропротекцию? И в чем тогда преимущество этого метода перед оптимальной медикаментозной терапией, которая в том числе может давать и нефропротективный эффект? Прежде всего, блокаторы РАС.
Спасибо за вопрос, я тогда отвечу быстро на русском. Да, этот за 5-летний период, то есть в течение года терялось по меньше 3 миллилитров, то есть это говорит о том, что меньше физиологической нормы потери, снижение СКФ. И есть исследования, которые показывают, что на 3-летнем периоде нефропротективный эффект у ренальной денервации выражен. То есть мы будем продолжать смотреть на большее количество человек.
Спасибо огромное. Уважаемые коллеги, мы двигаемся дальше. Напоминаю, что 6 минут лимит на доклад, 2 минуты, максимум 3, да, мы имеем на вопросы. Магомадов Иса Супьянович приглашается с докладом на тему Relationship between ID polymorphism of the ACE genated myocardial remodeling and features of the course of chronic heart failure in patients after coronary artery bypass.
Distinguished co-chairs, dear colleagues, I'd like to present our science. The study of genetic determinants of cardiovascular disease occupies an important place in concept of personalized medicine. The D allele of ACE gene is associated with higher blood concentration, angiotensin converting enzyme, and association with the increased incidence of myocardial infarction. The aim of our study to identify difference of course of heart failure and evaluate myocardial remodeling in patients after coronary artery bypass grafting during 18 months of follow-up, depending of ID polymorphism of ACE gene. For that, we conduct one open label single study and prospective study included 105 patients with coronary artery disease underwent CABG between 2022. Anamnesis and cardiac parameters detected before and after 18 months after CABG. Patients we divided in 2 groups depending of variants of gene. There was high prevalence of comorbidity and risk factors, but there were no difference in comparing groups. Based on 6-minute walk test, patients in both groups have had first functional class of heart failure. Natriuretic pro-BNP was 3 times higher than the diagnostic criteria of heart failure in both groups. Patients had high adherence of therapy. Main characteristics of operation are present in this slide. In both groups didn't have any difference. In hospital period, the incidence of mortality and post-operative atrial fibrillation was evaluated, but there was no difference between groups. More interesting changes we detected on 18-month follow-up period. There was in second group statistically significant change statistically changed left ventricle and diastolic volume increased, and this in its index left systolic left ventricle and diastolic volume and its index and left ventricle and systolic volume was increased in after 18 months follow-up. More interesting change in second group about diastolic dysfunction. There was an increase left atrium and left atrium index from 13 to 36 milliliters compared with combination with increase EE ratio from 20 to 12 to 15 indicates class 2 diastolic dysfunction with increased pressure in left atrium. In the second group, there was threefold increase in the frequency of acute decompensation heart failure, but we don't find any difference about overall mortality. Based on results of this study, we can do these conclusions in patients carrying the DD variant of ACE gene, progression of left ventricle myocardial remodeling after CABG is observed from increase of left ventricle and diastolic dimension, diastolic volume and systolic volume, as well as worsening in diastolic dysfunction from grade 1 to grade 2, and DED variant of ACE gene association with threefold increased risk of acute decompensation heart failure at 18 months after CABG. Thank you.
Okay, thank you very much. So the two questions. So actually, the studies in ACE polymorphism is not new, not novel. I remember it was some studies even 25 years ago about in this, and also about the first what is new, and the second about the control group. Did you have the same control group samples compared with the same age and same study characteristics?
Thank you for your question. About first question, yes, genetic polymorphisms studied in a few years ago, but about our study, we detect changes of myocardial remodeling after after coronary artery bypass grafting, depends of gene variants, because we have literature data about D variant have more aggressive in pathogenesis of heart failure, because we find difference about of variants. About second question, can you repeat your question? About control group, we use data, science data about Russian population, and depending of polymorphism of this gene. But we compared our groups, and they have same base characteristics.
Thank you very much. So the problem is with the polymorphism, usually the studies, so we have a number of the studies, so usually the bigger amounts of the cohorts. So in your cohort is not big, and so this, the important that you say the race and the nation is also important, should be surely, for example, only Russian population, because it's also has Tatar or Ukrainian or some, they have some impact.
I'm sorry, one small question. Thank you for your interesting presentation. And from what point of view, how you can use the results of your investigation in clinical practice?
Thank you for your question. I think we can do these conclusions if we testing genetic. If we will test genetic polymorphism ACE, and we know about this patient have D variant, we should use more maximize doses of inhibitors of ACE, or the best way in this situation in patients, we should use RNB, or last modern drug, it's sacubitril and with valsartan.
Thank you for your report. And can you tell me, have you considered in your follow-up the outcomes during the 4 years of your prospect study? And did you find any associations between the gene polymorphism and outcome to confirm this association? Thank you.
Excuse me, I don't understand. You mean which outcomes we detected, or
yes,
what
yes.
do you mean?
The outcomes, and did you find effect size, for example, relative risk? Did you count this between the
Yes,
associations?
actually, we have three. I'm sorry.
Not 4 years, 18 months.
18 months. Yeah.
We find of threefold increase association with acute decompensation heart failure. Yes, we detected another outcomes like myocardial infarction, stroke, and etc. But I presented main results.
Okay, thank you very much. So you may sit, and we continue our section. Ivan Borovikov from Irkutsk. Cellular induces systemic inflammation. Search for predictors of hospital mortality in patients with myocardial infarction in combination with type 2 diabetes. Please, 6 minutes.
Good morning, dear colleagues. Thank you for opportunity to the participants in your forum. Hematological indices of systematic inflammation calculated from the cellular composition of peripheral blood are simple, widely available indices that are calculated from clinical blood test. The prognostic role of these hematological indices in the risk of hospital mortality in patients with myocardial infarction with diabetes mellitus has not been previously studied. And aim of our research to evaluate the significance of hematological indices of systematic inflammation in the prognosis of hospital mortality in these group patients. We included 165 patients with myocardial infarction with ST elevation segment and diabetes mellitus during hospitalization from 2018 to 2020. Our study has 2 phases. First phase was comparative analysis mean between 2 groups with myocardial infarction and with and without diabetes mellitus. And second phase was a retrospective single center case control study. Criteria of inclusion and exclusion are shown is this slide. It's our study design. After comparative analysis, we determined association of these studied indices with development of hospital mortality. We used univariate regression analysis, then we used multivariate regression analysis, and for test we used ROC analysis. These hematological indices of systematic inflammation are calculated mathematically in this slide. As we can see, most of hematological indices decline in dynamics. And in group of patients with myocardial infarction and diabetes mellitus, inflammation has a slower rate of decline, as we can see. Result of second phase of our research, median survival in disease group 6 days. Main cases of death, acute heart failure and ventricular arrhythmias. Average age of these patients, we had 65-year-old. All patients were receiving dual antithrombotic and anticoagulant therapy, and they were after PCI. When we use univariate regression analysis, we obtained 8 prediction that increased risk of hospital mortality in these patients. But after multivariate regression analysis, with adjusting for sex, age, body mass index, serum creatinine, ejection fraction, and number of stents implanted, we obtained 3 hematological indices of systematic inflammation that increase risk of mortality during hospitalization. And after we tested our theory, we used ROC analysis with cutoff value and to test prognostic performance. Our conclusions. First of all, the group of patients with myocardial infarction with ST elevation and diabetes mellitus characterized by increased monocyte to high density lipoproteins ratio, delayed rate of high sensitive C-reactive protein decline within 48 to 72 hours after PCI, no significant decrease in neutrophil lymphocyte ratio, and degree of decrease in the monocyte lymphocyte ratio. And we answered of our question. We found out neutrophil lymphocyte ratio, systematic inflammation index, and a systematic inflammatory response index, the most independent predictors of hospital mortality. And totally, we created a mathematical model for predicting hospital mortality. Thank you for attention.
Thank you so much. The next question is, can retrospective study predict risk index?
Thank you for your question. I think not prognostic role. Maybe we studied association these hematological indices.
But in your
Design.
visual and design, risk increase, risk decrease, and what for you use the method of case control?
What for method?
Для каких целей вы использовали метод случай-контроль? Что он позволяет сделать по сравнению с обычным ретроспективным анализом?
If you think we compared 2 groups. One group patients with myocardial infarction and diabetes mellitus who survives, and second group who died. and we tried to evaluate these indices in prognostic.
Okay, thank you very much. I should say that it's well done. I mean, the methodologically it's a well-made study with the univariant, multivariant, and mathematical model. The only thing you could add, this is the hazard ratio for the each of the markers actually, and also it is indices is not typical word for this, or cellular indices. Nobody say it like this in the study. Usually markers or biomarkers, you usually say that cellular markers, something like this.
Yes, thank you for your comment. Is this scientific work is part of with in the future with biomarkers?
Thank you very much. So you may sit. So you don't need to thank you for this question. So it's like on your thesis with the you don't need, just answer, start to answer.
With great pleasure, I invite Iosif Center, Kemerovo, and his topic is prevalence of lipid metabolism disorders among coal industry workers. Please.
Dear Chairman, colleagues, the coal mining industry is the driver of the Kuzbas economy. Kemero region Kuzbas is the largest industrial region with a developed coal mining industry. Compared to other industries, coal mining is often associated with chronic non-communicable diseases. This association exists due to a number of traditional factors contributing to the development of lipid metabolism disorders as well as the specific of works. The aim of my research is to assess the prevalence of lipid metabolism disorders in coal industry workers, taking into account age and work experience in underground mining. The study included 2,356 male respondents. About 70% were mining industry workers and about 30% were participants residing in Kuzbas selected from the population sample of the ACD-RF multi-center epidemiological study. The respondents were divided into 3 groups depending on the age and on the work experience in underground mining. Lipid metabolism levels were assessed by total cholesterol, TC, triglyceride, TG, low and high density lipoproteins, LDL and HDL. This slide shows clinical and anamnestic characteristics of respondents. As you can see, the prevalence of non-communicable diseases is high in controls. The analysis of lipid metabolism parameters revealed that the median TC levels and its fractions and TG levels were within the norm in coal industry workers, whereas the participants in the compression group had statistically higher LDL levels. However, the incidence of hypertriglyceridemia and low HDL levels were statistically higher in coal miners, whereas the high incidence of hypercholesterolemia and high LDL levels were noted in more than half of the control groups. During the analysis of lipidogram with the division of participants into age group, it was found that the median of lipidogram indices were naturally within the norm in both groups in younger participants up to 30 years old. The higher the age was, the higher were the levels of TC and LDL. However, TG and HDL levels were within the norm in all age groups. Despite this, statistically higher levels of triglycerides were observed in coal industry workers. And high levels of LDL and HDL were noted in controls. There was a prevalence of participants with hypertriglyceridemia and low HDL levels in coal industry workers under the age of 30. In the control group of the same age, there was a prevalence of participants with high LDL levels. The revealed pattern can be noted in participants of other age groups. Moreover, even at normal TG levels, higher concentrations of these fractions were observed in coal industry workers. Thus, the control group showed a worse profile of lipid metabolism parameters. At the same time, statistically higher concentrations of triglycerides, prevalent hypertriglyceridemia and low HDL levels were characteristic for employees of coal enterprises regardless at age group. Comparing the parameters of lipid metabolism depending on the length of the underground work experience, the long work experience coincided with higher age, higher concentrations of announced indicators, and the higher prevalence of lipid metabolism disorders, although without statistically significant difference in some cases. The median of TG, LDL, and HDL levels corresponded to the reference values, while the median TC level was high in participants who have been working for more than 10 years. We characterized hypercholesterolemia as the most common variant of lipid metabolism disorder occurring in 1/3 of participants with less than 10 years of experience and up to a half of participants with more than 10 years of experience. Less common variants of metabolism disorders included hypertriglyceridemia and high LDL levels, which were observed in quarter of employees with less than 10 years of experience and third participant with 10 years or more of work experience. The least prevalent metabolism disorder included low HDL. 1/6 of the participants in each group had this type of disorder. The results of logistic regression analysis after leveling the effects of age and obesity revealed the longer work experience in underground mining was associated with a higher risk of dyslipidemia. In more experienced participants, more than 10 years of work, the risk of hypercholesterolemia and high LDL levels increased twofold, but the risk of hypertriglyceridemia and low HDL levels was slightly lower. Thus, the results of study demonstrated that lipid metabolism disorders were detected among 62% of coal industry workers. Hypercholesterolemia was the most common variant of dyslipidemia. The prevalence of hypertriglyceridemia and elevated LDL levels was similar, whereas low HDL levels were diagnosed twice as often. Participants with hypertriglyceridemia and low HDL levels prevailed in all age groups of coal industry workers. And in more experienced participants, more than 10 years of work, the risk of hypercholesterolemia and high LDL levels increased twofold. The risk of hypertriglyceridemia and low HDL levels was slightly lower. Thanks for your attention, colleagues.
Thank you very much. So we have Associate Professor Namitokov. He's experienced in cardiology and special color workers. Please, the question from you.
Well, when we talk about modern lipidology, we always try to include LPA in the analysis. Why you haven't included this parameter? Have no such.
Understood. Yeah, it's really the weak spot, maybe you call it so, in this period of research. But now I'm trying to modify my research, and now I'm already started to include LPA and even ceramides in my research.
Thank you.
Thank you for your report. What was your role in this study?
From the beginning, I tried to find the population of miners to compare it between coal miners and control group. But now I trying to modify the questionnaires for it, and I didn't say that. Of course, I process the data with statistical software and make those presentations.
Thank you very much. You can sit. Thank you for your answers. And we're moving on. The next speaker is Navid Rahimi, the postgraduate student of NIMU имени, named by Pirogov, cardiologist. The thematic of his report is what clinical factors are associated with the development of no reflow phenomenon in patients with acute coronary syndrome. Practice of this clinic. You're welcome.
Dear esteemed colleagues and distinguished member of academic member, it's an honor to extend my greetings to all of you. Today's presentation about what clinical factors are associated with the development of no reflow phenomenon in patients with acute coronary syndrome, the practice of Perigos City Clinical Hospital, number 1. Today's contents are introductions, methodology and data collection, results, conclusion, and references. By definition, as we know, the neuroflow is defined as inadequate myocardial perfusion in the affected area without angiographic evidence of mechanical vessel obstruction. To diverse the origin of neuroflow phenomenon, it's a divergent phenomenon. This phenomenon have divergent etiologies such as ischemia, reperfusion, and atrial embolism. And alongside there are more research which is in coincidence to emphasize the multifactorial nature of this phenomenon, such as the other research shows that the distal microembolization, the myocyte reperfusion injury, ischemic myocardial injury, and also genetic and acquired factors have a big role. Now I want to engage to our objective study was to determine the incidence of no reflow phenomenon and its related associated factors among patients with acute myocardial infarction undergoing PCI. For this, it's the method, the design was a perspective which starts from 2017 and 2022. So these patients all include 2090 patients. So we divide in 2 groups according to the thrombolysis scale, TMI scale. So the first group was 59 with initial TMI 0 and the final TMI 2. And the second group includes 149 patients with the initial TMI 0 and the final TMI 3. In the comparison of clinical and demographic characteristic of patients, we have found that except there were no statistically significance except the diabetes mellitus. And also about the comparison of angiographic characteristic, there were no significance except the level of lesion. So there are also, we identified the statistically significant results, such as diabetes mellitus. For the first group, it was 42.4, and the second group with the final TMI flu 3 was 22.8. So it means that the patients with diabetes mellitus are more prone to have no reflow phenomenon. And the significant predictor of neuroflow phenomenon is the proximal lesions. And the first group was 88.14%, and second was proximal lesion 39 and 60. The patient with proximal lesion have more prone to have neuroflow phenomenon. Also cerebral hemorrhage, the neuroflow was 4 times more frequent in patients with a history of acute cerebral hemorrhage compared to patients without previous history of acute cerebral hemorrhage. Patients with acute heart failure, according to the CLIP classification, are prone to have more incidence of no reflow phenomenon. So the patient with second CLIP classification is about 22, and 3 and 4 CLIP classifications, they have more incidence of no reflow phenomenon, start from 50 to 99. The incidence of in-hospital mortality due to no reflow phenomena was 6.1 times higher among patient group 1s in contrast to group 2. In conclusions, our study finds that the acute heart failure, according to CLIP classification, and pain balloon time more than 8 hours, the lesion level, except especially the proximal lesions, diabetes mellitus were the most predictor of neuroflow phenomenon. Recommendations due to our relatively small sample size and single center study, further multi-center research is necessary to provide a more comprehensive understanding of this topic. And also I want to appreciate the research members from our hospital, and special thanks to my professor, Professor Ekaterina Vladimirovna. And the funding was by Pirogov Russian National Research Medical University. And I would like also express my admiration for my hospital, to head of hospital, chief of, and professor, for their supports and facilities. Thanks a lot.
Thank you for a very interesting report. And my main question, what is the treatment of neuroflow in Pirogov Hospital?
I want to mention that in this study we did not include the treatment.
I understand,
Yes.
but just
as
to...
far away we are, there's multivariable manifestations, so we use adenosine, like also sometimes the CCB channel blockers like this, and so we have. I was not so engaged to our research was not concentrated to treatment of the neuroflow phenomenon.
I understand, but it's a very big problem in the world. What to do when you're in the operation room, you see neuroflow, and
we, as I mentioned, we use for adenosine, and we can use the glucoprotein receptor antagonists, like glucoprotein 2 and 3A receptor antagonists.
Thank you.
Thank you for your presentation. We know about this problem. It's a big problem. However, it's your information. It's no new information, because we know about mortality for a patient with neuroflow. So maybe this group have a different time of admission to hospital. It's first, and second, how myocardial infarction you include in this your work. Maybe it's only STEMI or non-STEMI.
I want to mention that our research was a little bit different. It was not coincidence with other research which have been done before. So according to the literature review, there are many research that emphasize that the age, sex, comorbidity factors like CKD, previous heart failure was coincidence or predictors of the neuroflow phenomenon. In our research, we have found that the pain to balloon time, more than 8 hours, the cerebral hemorrhage, the previous MI in anamnesis, the previous stroke, they have a big, they can impact the clinical situation, and also they are the predictors of neuroflow phenomenon. In our research, yes, we include the patients with ST elevation MI and also non-ST elevation MI. It was not concentrated just to ST elevation MI. So what was the reason that they came later they seek later the medical help? These patients, presumably the patients with ST elevation MI, they have a conjunctive decline, and also at the same time maybe the old age is a cause to they seek later the medical help, and the pain to balloon time was more than 8 hours for the patient with ST elevation MI.
Okay, but we know about you about it before. What new is your work?
The new work I've mentioned that the cerebral hemorrhage, the previous MI, the proximal lesion of infarct-related lesion, the level of lesion at the infarct-related arteria, And cerebral hemorrhage was our new findings, which was not mentioned in previous research. So it was not in coincidence.
Okay, thanks.
Yeah, suppose so. There are some new data. Of course, it's clear, so it's not new about neural flow, but it's a really important question. Okay, thank you very much. Please sit. So, as for the next report, Ksenia Rzab is not present here, so that's why we continue with Yekaterina Frolova. And from Barnaul, prognostic significance of epicardial adipose tissue thickness in patients with COVID-19.
Good morning. Good morning, dear colleagues, dear members of the jury. And now I'd like to talk about the, one second. About the prognostic significance of the epicardial adipose tissue thickness in patients with COVID-19 suffering arterial hypertension and obesity. Today we know that obesity is one of the risk factors and a potentiating mechanism for a number of diseases, including COVID-19. At the present known, it's a known fact that the epicardial adipose tissue serves as a SARS-CoV-2 reservoir and associated with severe symptoms of the new coronavirus infection. Several researchers have shown that the pro-inflammatory cytokines and angiotensin convertizing enzyme 2 expression and release in the epicardial adipose tissue is higher than in the subcutaneous adipose tissue. In some cases, the acute stage of COVID-19 is followed by prolonged course of the disease, and the condition is called long COVID or post-COVID syndrome. The aim of our research is to study the prognostic significance of epicardial adipose tissue thickness in patients with COVID-19 suffering arterial hypertension and obesity. Our study included 63 patients. Their average age of patients was 59, and their body mass index was 34. The epicardial adipose tissue thickness was measured during the hospital stage, and outpatient stage saw evaluation of the post-COVID syndrome data, which included results of survey, an exercise tolerance test, and a quality of life assessment carried out using a special questionnaire. As a result, all patients were delivered into two groups. The first group included patients with post-COVID syndrome, a total of 29, and the second group included patients without the post-COVID syndrome, a total of 34. Based on the data obtained, we contained a comparative analysis and estimated the predictive value of the epicardial adipose tissue thickness. During the hospital stage, all patients underwent multi-slice computed tomography with estimation of linear epicardial adipose tissue thickness behind their right ventricle. The comparative analysis showed that in the post-COVID syndrome group, measurements of epicardial adipose tissue were higher than in the group with patients without this syndrome. To estimate the predictive valuation of epicardial adipose tissue, we use a method of logic regression. And as a result, we came up with the following equation that you can see on the screen, where P is a theoretical probability of the post-COVID syndrome development, X is a specific value of the EAT thickness, and minus 3.3107 is an absolute term of the equation. The calculation give us the following results. Standardized regression coefficient of 0.4106 and the concordant percentage of 61%. The optimal cutoff value of the ROC curve was equal to or greater than 6 millimeters. And summing up, we can see that thickness of the epicardial adipose tissue was higher in the post-COVID group of patients. Apart from that, the epicardial adipose tissue thickness measurements showed correlation with risk of the post-COVID syndrome development in patients suffering essential hypertension and obesity, with the optimal cutoff value greater than or equal to 6 millimeters. And thus, the thickness of epicardial adipose tissue has shown the prognostic significance in the development of post-COVID syndrome and can be used in clinical practice to develop the individual approach to rehabilitation measurements. Thank you.
Thank you very much. Ekaterin, could you tell us, please, this is the not the whole results of your work, if I'm not mistaken. I skipped the information about the method which you used to assess the epicardial tissue. Is the echocardiography or a multispiral computer tomography?
Thank you. As you can see, you're right. It's part of our research, and in this presentation, we included just
CT. Yeah, CT.
Yes.
Okay. The next question. We talk about only epicardial tissue, but what about visceral obesity? Another substation of the visceral obesity, not only epicardial. Did you assess it? Did you manage it? We're talking with Джиоева Ольga Николаевна about that there is no results of multifactorial analysis. Did you assess the impact of another factors, another comorbidity, another social or demographic status of patients which can also influence of these results?
Yes, as I said, it's a part of our research, and also we have data that some clinical parameters like age, like using some laboratory tests, which also show us that patients with obesity have more chances to have more severe post-COVID syndrome.
May I ask the last question, please? With exception of adipose tissue, did you or will you assess the adipokine status according to laboratory tests also? Did you manage maybe expression of adipokines from this tissue or something else? What is the future plans?
Well, we will be happy if we have some opportunities to use these tests in our research, but nowadays we have no opportunities to use these tests.
And one small question. And what questionnaire did you use when you divided into two groups your patients about post-COVID syndrome? Yeah? Questionnaire.
Yes, it's a standardized questionnaire which is called EQ with like an international questionnaire.
Thank you.
Okay, thank you very much. But I should also say we have some also much big investigations in the COVID, and actually it is the relation between the epicardial fat and the COVID post-COVID is quite mutual. And to say that it is the direct could be the direct relation, but from my point of view, there are a number of different facts that has better prognostic value for the post-COVID, like CRP, the status, immune status, and so on. So there we have much more other factors that could influence more than the epicardial fact, because you cannot. So this is the epicardial fact. It's a chronic situation, and the COVID is an acute situation. Yeah. So that's why there is some difference between this. Okay. Nevertheless, thank you very much for the study. It was well done. The next is Nadezhda Danilchenkova, and from Krasnodar, some from. The host of all of us, and clinical characteristics of patients with not familiar hypertrophic cardiomyopathy. Please come on.
The history of studying of hypertrophic cardiomyopathy is more than 60 years. About 100 terms have been proposed to denote this disease. The fact that it's a genetically determined disease due to mutations of sarcomeric genes inherited by autosomal dominant type has been unchanged. The monogenic hypothesis is inapplicable in practice. Only about 30% of patients have pathogenic genetic variants. The other 70% of patients are not related to hereditary factors. Some features of phenotype cannot be explained only by genes. Objectives. The aim of the study is to observe clinical, morphological, and genetics profile of the patients with the non-familial form of hypertrophic cardiomyopathy in a multidisciplinary hospital. Materials and methods. The diagnosis of hypertrophic cardiomyopathy was based on echocardiography when left ventricular hypertrophy was diagnosed more than 50 millimeters without associated pathology or more than 20 millimeters in patients with arterial hypertension or aortic stenosis. The genetic testing was performed with using gene panel NGS Cardio 70 genes. 77% of patients were men. The average age was 57%. Oh, yes, the median duration of median history of hypertrophic cardiomyopathy was 3 years. 90% of patients have arterial hypertension. Also, patients had a coronary artery disease, type 2 diabetes mellitus, and obesity. The male clinical syndrome, chronic heart failure syndrome, was in 50%. Also, patients had edema, the pain in their heart region, and angina pectoris. Also, patients had atrial fibrillation. Echocardiography. The average LA size was 43 millimeters. The average left ventricular and diastolic volume was 49 millimeters, and the average value of the maximum left ventricular outflow tract gradient was 85 millimeters of mercury. In patients with non-familial hypertrophic cardiomyopathy, the phenotype of asymmetric obstructive hypertrophic cardiomyopathy prevailed mainly because of hypertrophy of the basal part of the interventricular septum with left ventricular outflow obstruction. Hemodynamically significant coronary lesions were diagnosed in 3 patients. The genetics testing. Interesting, but no mutations were found in 81% of patients. Results. The proportions of patients with sarcomeric hypertrophic cardiomyopathy was 5%. Considering the prevalence of the non-familial form of hypertrophic cardiomyopathy, it's necessary to search for new genetic and non-genetic factors that influence formation for the hypertrophic cardiomyopathy phenotype. Aristotle argued that the whole is greater than the sum of its parts. Hypertrophic cardiomyopathy is a complex disease. Genetic, epigenetic, and environmental factors are important. New knowledge about hypertrophic cardiomyopathy can influence the quality of life of patients and their families.
Thank you very much. Can you summarize what is new in your study? Maybe you can show the results. If not, no problem. What is novel in your study?
Our results is like vote results. For example, raw statistic that hypertrophic cardiomyopathy is about from 50 to 80% of patients haven't got genetic mutations. We had result that 81% of patients haven't got associated genetic pathology.
Much, and so we don't have much time, but we have the last our presenter, Talibova Sayala Mahmatkazi. Please, you're welcome. They were from Moscow, and evaluation of new marker marker systemic inflammation patient with coronary artery atherosclerosis.
Good day, dear colleagues. Thank you for your invitation. It's a big honor to be here today. Let me present the results of our study, evaluation of novel biomarkers of systemic inflammation in patients with coronary atherosclerosis. First of all, I want to say that chronic systemic inflammation is one of the components of pathogenesis of atherosclerosis. And the onset and progression of atherosclerosis is associated with the activation of the inflammatory process. And in the world literature, the recent literature described novel biomarkers of systemic inflammation, which are based on white blood cells, which are the systemic inflammation index, the systemic inflammation response index, and the aggregate systemic inflammation index. These indices have been found to predict poor outcomes in patients with colorectal and esophageal cancer more accurately compared to hematological markers based on white blood cells, like neutrophils, lymphocytes, and monocytes. These novel biomarkers was presented as possible prognostic factors for mortality in various cardiovascular diseases. In cardiac patients, for example, the level of SIA was associated with increased risk of ischemic heart disease and its increased severity. The goal of our study was to compare the levels of novel biomarkers of systemic inflammation in patients with atherosclerosis and without it, which were confirmed by data from instrumental examination methods. Before we start, I would like to show you how our indices was calculated, and you can see that this indices was based on complete blood count, and also we analyzed neutrophil lymphocytes ratio, platelets lymphocyte ratio, and monocytes lymphocytes ratio. Our study was a retrospective cohort study, and the cohort study included patients who underwent, who was suspected to have ischemic heart disease and who underwent selective coronary angiography. And exclusion criteria were concomitant cancer, autoimmune diseases, chronic liver and kidney diseases, and steroid use. And also patients who underwent an open heart surgery in the anamnesis or had any previous surgeries within the last year. Also patients with dilated cardiomyopathy. From the initial sample of 1,258 patients, only those who met the inclusion and exclusion criteria were selected. The study included patients, 901 patients with the average age of 61 plus minus 10 years, 60% of which were men. Patients were divided into two groups: with atherosclerosis, this was 609 people, and without atherosclerosis, 292 people. The statistical analysis were carried on using Statistica and Metcalc, and propensity score matching was performed using IBM SPSS. So you can see that we used propensity score matching. It was used in a ratio 1:1 to statistically adjust the baseline gender, age, and other clinical differences, which you can see on this slide. After PSM, there were two groups with both having 251 patients, and the studied indices of systemic inflammation were calculated for each of them. All the studied indices were statistically noticeably higher in the patients with confirmed atherosclerosis than in patients without it, you can see on the slide. And also, in addition, statistically significant differences were of the NLR and MLR were observed, but no statistically significant change occurred in the PLR levels. ROC analysis showed us the threshold values for studied indices, which are for SIRI over 1.05, for SII over 368, and for AISI over 248. 48. And comparing each of the ROC curves, the area under the curve was the largest for SIRI and slightly smaller for AISI. So two conclusions. The novel biomarkers of systemic inflammation were statistically significantly higher in patients with confirmed atherosclerosis than in patients without it. Elevated values of AISI, SIRI, and SII increased the risk of developing atherosclerosis of coronary artery, and as a consequence of the development of ischemic heart disease, and threshold levels associated with atherosclerosis were for C 1.05, for C 368, and for AIC 248. So thank you for attention. I would like to.
Thank you so much. Can you show once again, please, your inclusion criteria? Because in your inclusion criteria, the age level is up to 18. And what is the upper level? Because if you compare the levels, you also should include the age factor. And maybe when you divide in subgroups, because levels of different biomarkers, also systemic inflammation, may be one of cause of biological age. And maybe when you divide in subgroups, maybe 18, 40, 40, 60, 60, 75, and upper level, because 18 and 100.
Yeah, it was an idea, but we wanted to, first of all, analyze these 100 people who underwent coronarography, and to research if there are any statistically significantly differences between atherosclerosis and non-atherosclerosis. And later we will expand our research, and we'll put some new criteria, and we'll analyze this, of course.
This is correct, and you should answer to Professor Joy that we performed propensity score matching that balance the difference in the age. So with the professor. And the second question, with this study, so this is quite the study that with this study you say that there is a very big value and importance of inflammation in atherosclerosis, but this idea is actually is not so sure in the previous in the actual in the different studies. There should which we the researchers, they divide into different phenotypes. Actually, there are some inflammatory phenotypes of atherosclerosis and some others. And in this study, you showed just with these parameters, it is inflammatory phenotype of atherosclerosis. This is probably so. Your study is well constructed. Maybe it is. This is the truth. But so in different studies, it was differently shown. And also, this is for discussion. And the second, we have the standard, world standard for the inflammatory genesis of atherosclerosis. This is high C-reactive protein, and you should also compare to the level of C-reactive protein. Actually, if you speak about the level on inflammation in the atherosclerotic patients.
Of course, for the second question, we have chosen these indices because it's easy to use in the real practice. For example, in the clinical ambulatory, because all the patients underwent the complete blood count, and on the base of this blood count we can calculate, yes, calculate these indices, and we can see if the patient is in the risk group for atherosclerosis or having it.
But C-reactive protein is also very simply to investigate in the clinic. One question from audience or from our. Sorry. So we have the last person. Thank you very much. So you may sit. So we don't have the time because the person who Arzaeva Ksenia, who was missing, who was searching for her, she at the end appears to have the online connection, and we ask her to start her presentation about the stenting of critical aortic cartation is in a very low weight newborn by carotid artery access, Novosibirsk.
Good morning, dear colleagues. You can hear and see me. Sorry for my online translation. And let's start. A weight of less than 1,500 grams is considered to be a very low body weight. And so in critically newborns, especially those with very low and extremely low body weights, the strategy of open surgical correction of aortic cartation is associated with high mortality in the early post-operative period. Spontaneous closure of the arterial duct within the first hours of life is followed by a rapid deterioration in condition, cyclotoral collapse, and impaired tissue perfusion below the cartation level, leading to multiple organ failure and the development of metabolic acidosis. And decreased renal perfusion in water balance results in water balance disturbance and fluid retention, increased lactate levels, and progression of heart failure and acidosis. And breaking the vicious cycle only after open surgical or transcatheter corrections. And here I want to say that transcatheter techniques are an alternative and open surgical correction in these cases, and stenting of aortic cartation in critical newborns, especially in patients with very low and extremely low body weights, is an intermediate step and a bridge on the road to radical correction of this defect. And now about clinical case. A 28-year-old premature girl weighing 1,100 grams was admitted to the intensive care unit of the Mishalkin Clinic with a diagnosis of congenital heart disease, including hypoplasia of the aortic arch, cartation of the aorta, an open ductus arteriosus, and atrial septal defect of the secondary type. Is known from the medical history that laparosynthesis was performed on the second day after birth. Intestinal discharge from the abdominal cavity was obtained, and laparotomy was done. And then the resection of Meckel's diverticulum and double ileostomy were performed. And upon examination, the child had pale gray skin with a cyanotic tint, tachycardia at a rate of 170 beats per minute, different blood pressure in the arms and legs, with a saturation of oxygen in the arms at 97% and the legs at 72%. Anuria was noted after 12 hours of admission. And upon arrival, a transthoracic echocardiogram was performed, which revealed the ductus arteriosus at the stage of spontaneous closure and characterization of the aorta at a typical location with a peak pressure gradient of 47 millimeters of mercury. And the chest computed tomography scan confirmed the echocardiographic data. The lumen size you can see here in the cartation area is approximately 1.2 to 1.5 millimeters. And taking into account the very low weight, body weight, unstable hemodynamics, and assessment of the risk-benefit ratio, we decided to gather open surgeries we decided on palliative treatment using stenting of aortic isthmus with hybrid access through the right common carotid artery. And the first stage identified the right common carotid artery. It was hybrid access from neck. You can see in the first picture. The vessel had a diameter of 3 millimeters, and after directly puncturing the carotid artery, a 4-inch introducer was inserted, and then antegrade autography was performed to visualize the seat of the cartation. And then position of the coronary stent. And here you can see stent implantation and control orthography is good with no gradient, pressure gradient. And the post-operative course was uneventful and according to the echo control. The stent lumen is 4.4 millimeters and blood flow is smooth and not accelerated with a peak gradient of 5.5 millimeters of mercury. And left ventricular contractility is good, and there are no regional contractility abnormalities. And the condition stabilized on the 10th day after the operation. The child was transferred to regional children's hospital for further care, and radical correction of this defect is recommended when a body weight reach 5 or 6 kilograms. And in conclusion, I can repeat the stenting of aortic cartation critically newborns, especially in patients with low and extremely low body weight, is an intermediate step and bridge on the road to radical correction of this defect. That's all. Thank you for your attention.
Спасибо большое, Ксения Осифовна. К сожалению, мы не имеем времени на вопросы. И сейчас, глубоко уважаемые коллеги, наши члены жюри подводят итоги, о которых вы узнаете сегодня на завершающей пленарной сессии. А сейчас я попрошу всех участников подойти за сертификатами участников. Всем огромное спасибо. Вы большие молодцы. И несмотря на определенные сложности, мы все равно будем обязательно продолжать эту добрую традицию конкурсов на английском языке, потому что врач – это профессия, которая должна знать английский язык и уметь доложить спокойно и на своем родном языке, и на международном английском. И вы уже большие молодцы, что сделали это сегодня здесь на конкурсе молодых кардиологов. Удачи! Сертификаты, пожалуйста, заберите. Так, на вид. Так, Иосифу Марковичу кто передаст? Да, отлично. Иван Федорович. Иса Супьянович. Кто может Исе Супьяновичу передать?